Good afternoon, everyone. Welcome to the Montreal Heart Institute. I am Dr. Nosser, and with me here is my dear colleague.
My name is Philippe Lallier.
And my name is Sebastián Marat. I'm a fellow from Buenos Aires, Argentina.
And we're privileged to be working with our great team of personnel, Audrey, Véronique, Valérie, and Naili. Today, we'll be taking you through a step-by-step approach to CTO PCI for the non-CTO operator. So the objective of the case today and the presentation are understanding the fundamental aspects of CTO PCI and its setup, analyzing CTO angiography and the process of lesion decortication, reviewing the various antegrade techniques and wires used in CTO PCI, and finally exploring the basics of retrograde approaches in CTO PCI. So Sebastian will present the clinical case.
A 77 male patient with risk factors known of hypertension and dyslipidemia, presenting to our center with angina, dyspnea, and a low ejection fraction, transthoracic echo that showed a left ventricular ejection fraction of 40% with a mitral regurgitation, severe mitral regurgitation, inferior wall hypokinesis, and a MIDI that showed severe ischemia on inferior and inferior lateral territory. The laboratory showed normal blood cell count, electrolytes, and renal function. Initially, we aborted with an angiogram performed on March of this current year that showed a proximal circumflex disease that was treated by that time, and also a mid-segment of the right coronary artery with chronic total occlusion that was referred for a second stage treatment. The patient remained symptomatic despite the revascularization of the circumflex artery and the optimal medical treatment.
So if we look at the criteria for appropriateness for revascularization in this case, we're dealing with a symptomatic patient that has ischemia in the related territory that is already on optimal medical management. And if we go through the table, then revascularization becomes uncertain, but depends on how you take the symptoms and how you take into effect the low ejection fraction that's 40%. So it's either uncertain or it's adequate to perform the revascularization. And since the patient remains symptomatic with shortness of breath and occasional angina, we decided to go ahead with the revascularization of the CTO. So we'll discuss the basics of dual injection angiography. When doing CTO PCI, it's very important to have an initial setup of a dual injection angiography at low magnification, permitting you to see both coronary arteries in the same frame. And when you start, you inject the donor vessel first. That way it fills the collaterals and goes to the target vessel. Then you wait 1 to 2 seconds, then you inject the CTO vessel. Very important not to do panning, because panning deviates the eye from the target collaterals and properly observing the proximal cap and the distal cap. And then you perform cine until the dye clears. So there are 4 key questions that you want to answer when you perform the dual injections. First of all, you look at the proximal cap. Now, is the proximal cap ambiguous or is clear and tapered? Then you look at the lesion length, because the lesion length will determine a lot your strategy, either being antegrade or retrograde, and which type of antegrade strategy that you will choose. And then you observe the distal landing zone, because if you have a good distal landing zone, it will change how the procedure evolves. And the collaterals, very important to look at collaterals. Are there bridging collaterals? Is there septal collaterals or epicardials? And to what degree are the collaterals developed, the tortuosity? All these are questions that you need to answer when you do your dual injection. And then you go through the hybrid algorithm. So we'll review currently the angiogram, and I'll let Philippe take over here.
Sure. So the angiogram is actually performing exactly as Dr. Nosser mentioned. We have the injection first in the left system, which is the donor vessel, and then after 1 or 2 seconds, injecting the right. Hopefully, we can have this angiogram up on the screen. We can actually see again the left system injected first. Then, of course, after 1 or 2 seconds, injecting the right, we see both vessels. We take orthogonal projections to see it in different views. So first and foremost, when we inject the left system, we confirm there are no severe lesions that would actually change the overall strategy for this patient. We see no restenosis of the circumflex PCI that was performed 3 months ago, and we see no progression of the disease in the LAD. So we're satisfied with this particular portion of the evaluation. And of course, when we look at the right coronary artery, we can actually see there are bridging collaterals that are somewhat of an issue because, of course, the wire will have a tendency to go through them. Second is that we can see nice collaterals coming from the septal perforators of the LAD going to the PDA, filling the right coronary artery retrograde. And we can also see part of the landing zone being vascularized by bridging collateral. We see a good landing. Okay, so as far as the angiogram is concerned, we inject the left system first. We see the collaterals going to the distal part of the RCA. We inject the RCA a few seconds later. You can actually see the occlusion, which is about 15 millimeters in length. We see significant bridging collaterals, which make it a little bit more difficult to pass the wire through. So we need to recognize this first. The tip, the entry point is blunt versus ambiguous, but still possibly more blunt than ambiguous. There is a branch right at the occlusion site. And of course, when we see the landing zone appears to be fairly good size. So we consider it a good landing zone. So when we use the JCTO classification, we scored it as a JCTO score of 1 due to the blunt tip. There is minimal calcification, angulation is limited, and overall performance of this PCI for us would make us go through an antegrade wire techniques. So we see orthogonal projection, which is of course key to evaluate angiographic disease, no question about it, it's important. So we take at least 3 projections to see, again, whether there are a restenosis or progression of the LAD before we actually go through the PCI. Very important to reassess the situation carefully.
Can we have our slides, please?
Can you guys show the slides, please? Yeah, so the initial stepwise plan, we'll pass the microphone to Dr. Nozer. He will actually mention the actual strategy.
So since we're dealing with a JCTO score of 1, the initial step plan logically has to be antegrade wire escalation. The only difficulty you anticipate at this point is that there's kind of a blunt stump and there's a bridging collateral coming right off and there's a small branch, but probably won't be that much of an issue. We'll see that. This is our choice of wires in a ascending manner. So we're going to start with the Fielder XTA to see if there's a microchannel that connects that's invisible. Then if it doesn't progress, we'll still stay in the polymer jacketed wire, the Gladius, and we'll see how that one goes. If we manage to get subintimal at this point or intraplaque, then maybe perhaps form a knuckle and try to get parallel to the lumen and try at this point a sting brace re-entry. If the Gladius doesn't go as expected, then we'll give a go of a Gaia second next. Since the Gaia is very directive wire and we have a short CTO, it's worth giving it a try if it avoids antegrade dissection and re-entry. Now, if we cannot get through with using antegrade wire escalation, we'll move to ADR. So ADR, as I mentioned, a knuckle followed by a stingray. If that doesn't function, then we have a retrograde option, which was the second septal. If we can show the views, we'll perform septal surfing. So we see through the LAD injection that there's good septal connections, and we can actually trace them through the septum to the PDA. So that would be our third option. We'll use the probably cyan wire at this point or cyan black. And depending on how we approach the distal cap, either retrograde wire escalation or we'll have to do reverse cart. And if our bailout strategy would be STAR and investment procedure for next step. So without further ado, we'll start working. And I just want to show you how we shape the wire. If you can zoom in on my hand. So I already have the tip done, which is a millimeter at the tip and a bend. That's the Fielder XT. And we'll go ahead. So we already have the Corsair Pro XS. We have a right radial XB35, which is the donor vessel with a wire in the LAD. And we have a AL 0.75 through the right femoral, 7 French. We have a Corsair Pro XS 150 antegradely, and retrograde, we don't have a microcatheter yet, but it will be the same one. So we'll see what the XT does, if you can find the microchannel. So we can already see the wire buckling, which indicates that it's stopping at the lesion.
We purposefully have two setups to distinguish both catheters. So if we're going to do injections from the left system, it's going to be through the automatic injector. And if we're going to do manual injections, they will be through the RCA catheter.
So here, when you do an orthogonal view, you want to see where the wire is compared to the lumen. So I'm just right on top, and both are dancing in the same plane. So very important before advancing gear is to check where you are compared to the lumen in two orthogonal views, because a wire perf is forgiving, a gear perf is not forgiving. So let's go back to the LAO view. And I'm going to advance my microcatheter, and I think at this point I'm going to switch to the Gladius.
So Mohammed, tell us how you know you're subintimal as opposed to close to the true lumen.
So I'm looking at how the wire is moving distally. Normally, if I'm in the true lumen, it should slide at this point, which is not happening. So we're going to take the Gladius Mongo. So I'm advancing the microcatheter. Now it's mid-plaque. We'll check it retrogradely. I'm going to switch to the Gladius. So Gladius is a polymer jacketed wire. It's one of the most recent additions to the CTO arsenal. It has a 3.5 gram tip. It's a dual core, and it has a very specific characteristic that the tip is very foldable. So it's a very favorable wire for forming a knuckle. You think about it as a Pilot 200 upgrade. Actually, I do most of my CTOs with the Gladius and with a success rate of about 70%, I would say. And since it's polymer jacketed also, it's very rarely perforates, stays in the vessel architecture. So let's see what the Gladius does.
So your tip shape of this wire in order to progress, is this pretty much the same as previously?
Same. But with the knowledge that it will knuckle a much more controlled fashion.
And your objective now is to re-entry or knuckle?
I'm trying to re-enter. I'm going to try to find another microchannel that re-enters. It's a very good wire to direct, and I think I have a tip is free. So let's do a cine here, see where I am. We have less flow antegrade now. I'm trying to redirect to go into the RCA because into this. Okay, that looks good. Can you please test? Okay, so I'm torquing the wire manually, and I'm trying to follow the die, and here we go. And once I figured I was in the lumen, I saw the die in the distal bed, and then I just maneuvered the wire, make sure the tip is moving, that I'm not in a subintimal space, not to extend the hematoma, not to create any dissections. And I think seeing the wire like this, it's pretty much confirmatory. And at this point, we'll advance the microcatheter and switch for a workhorse, and then we're ready for imaging. So take a look at my hands. I want to show you how to manipulate the microcatheters in this setting. It's very important to have one hand transmitting the torque, one hand controlling the torque. And then you do at least 10 turns and 10 turns. Avoid over-torquing on one side, because if you over-torque on one side, microcatheter can break and you might lose the tip. So I'm having significant resistance at the lesion, but it's still advancing. It's very important not to push it. Just be a controlled manner and advance slowly and gently.
One of the pearls is that while you do all these injections, you're not looking always, and you're not seeing as well as you should possibly the guiding catheter in the left system. So putting in a wire in place to stabilize the wire, making it coaxial and keeping it coaxial throughout is kind of a safety measure. We strongly suggest you put in a workhorse wire in the LAD while you perform these tests and the CTO PCI of the RCA in order to keep it safe for the left system.
So our plan at this point is to perform imaging, to have an idea if we crossed everything, intraplaque, extraplaque, also and to understand if we need to do any kind of plaque modification, depending on the calcium findings. How do you remove the microcatheter at this stage? So there are multiple ways you can remove the microcatheter. You can either trap, you can hydroglide, or if you have a trap liner, you can use the trap liner. I think in this case, we will do a hydroglide. The way to do that is make sure the tip of the microcatheter is full of dye. You lock it, make sure you don't trap the wire. Then your colleague inflates at a high pressure
And keeps it at the same pressure while it comes out.
And it comes out and nothing moves, and you can look at the wire. I have a knuckle at the workhorse, so it's pretty safe. And now I think we'll perform some dilatation with a 2.0 by 15 or 20 balloon for the IVUS. So this is a 2.5 12. So we'll be gentle. Let's go.
Okay, so we test first to see if it's in the right place, or
Yeah.
So because there is a proximal disease in the RCA, we still have not injected a single time in RCA directly. The RCA guiding catheter, so it's 6.
So we're ready for IVUS. Usually when you're dealing with CTOs, the distal bed is underfilled and there's negative remodeling. And when you open up the CTO, there's positive remodeling that happens. And if you do not properly size your stent, then you risk of having worse long-term outcomes with ISR.
So the IVUS catheter is currently the Refinity Philips Volcano system, the 45 megahertz system. The tip has been improved, so it should track better than the previous type of catheter.
I think this is a good place to start.
Okay, we're going to start imaging, see if we have a
Image
good
is
image.
good.
We're going to make sure we don't have a nerd as much as possible. Image quality appears to be super good to us. We have limited disease in this segment, which is what we expected from angiography.
There's the bifurcation that we're talking about, so we'll try to stop before that.
Now we see a plaque throughout the vessels, not very severe. Another branch. And we see a calcification, which is kind of spotty at this time. We are probably close to the lesion initially. So we see calcium, but it's a little bit superficial. We've never seen anything more than, it's always been less than 90 degrees. So Mohammed, what's your assessment? I don't think we actually need to do plaque modification.
No, I don't think so either, I agree.
So I think right now the length of the calcification and the extent of calcification does not seem enough for us to justify plaque modification. So we think we're going to go through balloon.
Yep. How much is that? 3 millimeters. This is the beginning of the run. Distal landing zone. Can we stop somewhere in the middle to get a measurement?
Now, of course, it's a diffuse disease, so we'll need to measure the vessel and downsize the stent.
Yeah. 3 So I think if we do a 3.0,
yes, so
it should be okay.
yes,
It's 3.4. I think if we stick to 3.0. What do you think?
So now we have a 3.7, let's say 3.75. We need to downsize by at least a half a millimeter. So we'll use a 3.0 balloon and stent.
Looks like we have some resistance there.
Yeah, it's only 8. We're going to increase a bit the pressure to 12. Yeah, 14.
Okay, I think it's expanded now. Yeah, looks okay. But what would have been your choice had we not been able to expand this in terms of calcium modification?
Interesting. Of course, if this would have been the case, of course, we need to go back. I think the calcium was fairly superficial when we look at the IVUS. Of course, the IVUS will not be able to tell you whether it is deep as far as the thickness is concerned, but I think I would have used rotablator.
All right, let's see retrograde if we still have some flow. Yeah, we'll do a nitro anti. So there's almost no more flow through the retrograde. So that means we have good flow antegrade.
Good enough for us to assess and try to start to do stenting.
It looks significant to me here.
Yes.
I think we need to cover it and we'll manage that branch afterwards, or you want to put a wire?
I think we put a wire.
Let's get a run through, please. And let's start looking for a 3.0 48 synergy. And if we don't have that, then we'll take a 3.0 38. So for sure, the workhorse needs to navigate the proximal plaque. It's well open, the vessel. Should be okay, but we'll see. If ever there's issues, we can always use a dual lumen catheter. But it's very important to use a workhorse wire here. Okay, that looks like the correct branch.
Yeah.
Yeah, that's correct branch. So it's an early takeoff PL. We still want to preserve it because you want to preserve most of your branches if you want to have good results on your CTO. So I think we went through all the steps of CTO that we would have done hadn't this worked, but we were lucky enough that the antegrade wire escalation worked. I think it's a very good lesson that no matter what collaterals you have and how much you think it's difficult, you should always go at it antegrade.
Yeah.
because with the wire technology that we have right now.
And as you go through and as you progress through your experience, you will eventually understand what every single wire can actually give you as far as performance. And it's very important you use them in different scenarios, different clinical situations, even during your standard regular complex PCIs, so that you really eventually fully understand what each wire can actually give you and when you should use each one.
You want to do it? Let's do let's get another run through. So the branch is jailed. The distality looks pretty good. So we're going to try to recross in that branch and inflate a small balloon. We'll just do a provisional at this point. Yeah, so I think luck is on our side. All right, let's take a 1.5 balloon, please. And then we'll go a 1.5 and a 2.5.
Want to pull the other wire?
I'll leave it for now. It will be when you cross a side branch and you have a jailed wire, it's very useful to keep it in place until your balloon is through. That way it gives you some support to pull on the balloon. So I had issues passing a run through. In that case, I don't think trying a 2 is a good idea. We'll start with a 1.5 15 balloon. Yeah.
And of course, the plan for now is to optimize the bifurcation. Once this is done, of course, stent until we reach our proximal landing zone, which is in this case the ostium of the RCA.
So can we get back our slides? Because I see it's getting to 3 o'clock. The rest of this is just basic, usual stenting. And we're going to deal with the bifurcation provisionally. We're going to implant another stent proximal, and then we'll do IVUS to finish off. If so, we'll just go to our slides and leave you guys with some conclusions.
So, of course, if you guys are not lucky enough to be scrubbed with Dr. Nozer, who actually succeeded at passing this wire, made this look so easy that you want to give it a try immediately. But you need to be ready to do any other type of technique if you have to. So success rate is actually dependent on being able to go to the next step and eventually plan for whatever you need ahead of time. That's very important. Second is that you need to assess the angiogram carefully from the beginning and plan ahead for plan A, plan B, plan C, where this is absolutely key. And you have to be able to look at the angiogram. Dual injection is, of course, something that you cannot go around. You need to do this in order to fully understand the anatomy and the relationship between collaterals and the actual occlusion.